Hello and welcome. My name is Monica Salvia, and I am the Associate Director of Alumni Relations at the University of Pennsylvania School of Nursing. It is my privilege to serve graduates of Penn Nursing with programs and events such as our webinar series. At the end of today's webinar, I will share information about other upcoming programs and opportunities to engage with the school and one another. So let me begin by thanking the alumni, faculty, staff, students, parents, and friends who have joined us today. This afternoon, I have the honor of welcoming all of you to the Future of Pain, Optimizing Multimodal Analgesia in a New Era for Managing Pain, which is a webinar sponsored by Penn Nursing alumni and featuring Dr. Rosemary Polomano. This webinar is scheduled for 1 hour. And before we get started, let's go over some of the basics on using the webinar features. Remember, everyone is muted on the call so we can reduce background noise. And during the presentation, you can communicate with the organizers about any technology concerns via the chat function. You can submit questions for Dr. Polomano using the question function. So let's just take a look at this. On the right-hand side of your screen, you should see the GoToWebinar control panel, which you can maximize or minimize to your preference. This is typically a gray box that provides you with information on the webinar functions and ways to interact with us. So let's start with the control panel in its maximized position. Near the bottom of the box, you'll see a section heading. This is titled Questions. This is where you can type questions for our speaker, and again, you can do that at any point during the webinar. Dr. Polomano will answer as many questions as possible at the end. Many were received in advance, so note that those questions we have received and do not need to be resubmitted. At the bottom of the control box, you'll also see a section titled Chat. This is where you can communicate with the organizer about any concerns during the webinar. So the final feature that I would like to point out is the raised hand function. And I'd like to conclude our overview by checking everyone's audio. So if you can hear me, I'm going to ask that you virtually raise your hand using the hand icon. And I'll give everyone a minute to locate and click that icon. And while you are clicking that hand button, I want to remind all of our participants that today's webinar will be recorded and it will be made available to you later this week. All right, thank you. It looks like all of you can hear me, which is terrific. So now it's my honor to introduce our speaker, Dr. Rosemary Polomano. Rosemary Polomano is Associate Dean for Practice and Professor of Pain Practice at the University of Pennsylvania School of Nursing and Professor of Anesthesiology and Critical Care at the University of Pennsylvania Perelman School of Medicine. A Penn Nursing BSN and MSN alumna, Dr. Polomano received her PhD from the University of Maryland School of Nursing and completed a postdoctoral fellowship in laboratory research at the Hahnemann University in Philadelphia. She is a member of several professional organizations and national advisory boards, task forces, and expert guideline panels to address national agendas for pain management. She also serves on several scientific grant review committees. Dr. Polomano's research focuses on instrument development and testing of patient-reported pain outcome measures, advancing the translation of pain science to practice, post-surgical and cancer-related pain, and acute and chronic pain in military service members and veterans. She has lectured extensively throughout the world on pain-related topics, including the assessment and management of acute and chronic pain. She has been the recipient of numerous scholarships and has also received national research awards for her investigations related to acute and chronic pain management. She is a fellow in the American Academy of Nursing and serves as a magnet appraiser for the American Nurses Credentialing Center Magnet Recognition Program. Dr. Polomano has published over 100 peer-reviewed journal articles and 35 book chapters. She's a busy lady. So welcome, Dr. Polomano, and let's begin the presentation.
Thank you, everyone, for joining us this afternoon, and it's my privilege to have this opportunity to review with you some aspects of the future of pain, some past aspects of pain, but optimizing multimodal analgesia. And so I did receive several questions from several of you, and unfortunately I won't be able to get to all of them, but certainly if you have a pressing issue, you can always contact me at a later date. So the first thing I wanted to do was to just talk a bit about the physiology of pain. And this slide depicts the mechanisms, the processes, and the pathways for pain. And basically, we're going to use this illustration to talk about multimodal analgesia. So just briefly, I want to go through the 4 aspects for the transmission and the processing of pain. So the first is there's transduction of pain, which is the activation of nociceptors. They're free nerve endings capable of picking up on pain. Then an electrical signal is propagated, and this signal comprises the process of transmission. And these signals will travel through nerve fibers, and you'll see that there are C fibers and A beta fibers and A delta fibers. C fibers and A delta fibers are pain fibers. A beta fiber is a touch fiber. But these fibers will transmit information into the dorsal horn of the spinal cord. And then pain will ascend to higher levels of the brain. And in the higher levels of the brain, that is where pain is perceived and processed. But one important aspect of the modulation of pain is the ability, and if you look on this illustration, this blue pathway, is the ability to modulate pain through descending pathway modulation. And this pathway starts at higher centers of the brain and will send impulses and send information that will blunt or dampen pain signals from ascending to the higher centers of the somatosensory cortex. And this descending pathway is particularly important in modulating and decreasing pain. And we'll talk about ways through multimodal analgesia where we'll capitalize on the function of this pathway. Now, the next slide I just want to briefly mention, and you all know that there is a classification of pain. Pain can be classified as acute pain, and that is usually pain that's less than 90 days. Postoperative and trauma pain would comprise acute pain. And then there's chronic pain, that is pain that it lasts for greater than 3 months. But there's this acute persistent pain. And this is pain that transitions into chronic pain. That is acute pain that lasts longer than a week or two and transitions into a chronic pain state. And then with chronic pain, we have nociceptive pain, pain that comes from the activation of these pain receptors, mixed pain, which is a combination of nociceptive pain and neuropathic pain. And neuropathic pain is pain that comes from damage to the nervous system itself and the nerves. And under chronic pain, we see chronic non-cancer pain and cancer pain. And so I'm going to be talking a little bit about acute pain and a little bit about chronic pain and a lot about using multimodal analgesia to try and prevent the transition of acute persistent pain into a chronic pain state. Now, how does acute pain progress to chronic pain? Well, the process is extremely complex. But within hours of acute pain, there is always the risk that severe acute pain can transition into persistent acute pain and then to chronic pain. And I just have listed the different mechanisms as to how this happens. But one of them is central sensitization, which is a process that leads to hyperalgesia, a heightened pain state. And allodynia, hyperalgesia, is a manifestation whereby you have exaggerated pain to a stimuli that is not typically painful. And allodynia is pain from stimuli that hyperalgesia is a response to pain that is typically painful, but it's an exaggerated response. And allodynia is pain that is from a stimulus that might not be very painful, such as touch. And so when we look at the transition, for example, of post-surgical pain, acute pain, to post-surgical chronic pain, this is a state that really exemplifies how acute pain can transition into chronic pain. I want to very simply state that everyone with chronic pain had acute pain. And everyone with chronic pain was likely to have acute pain that was not adequately treated or managed, and this transitioned into a chronic pain state. Taking, for example, the consequences of just not relieving acute post-surgical pain. Patients who have unrelieved post-surgical pain with certain procedures can run the risk of getting chronic post-surgical pain. I've listed the different surgeries that are associated with a very high incidence of developing a chronic post-surgical pain syndrome. For example, inguinal hernia has a risk for transitioning into a chronic pain syndrome, mastectomy, thoracotomy, and amputation. Severe acute pain predicts the likelihood or is a culprit in the transition of acute pain going to a chronic pain state. Another example of chronic post-surgical pain relates to total knee arthroplasty. We're just learning that 10 to 34% of patients undergoing total knee arthroplasty can develop a chronic pain syndrome, 7 to 23% of patients undergoing total hip, and less than 10% risk is associated with minor and major general surgery, so that patients having a laparoscopic procedure could run the risk of developing a chronic pain syndrome from that procedure. Now, how does exactly acute pain go to chronic pain? Well, the mechanism and cascade of events are extremely complex, but this is a simple depiction of what happens. First of all, there's tissue damage. Then there's an inflammatory response. In the periphery, there's sensitized active neurons. There's neurons that weren't active and were dormant that now get recruited into an active state. There's an amplification of a noxious process in the periphery, and there's peripheral sensitization, where the peripheral nervous system is hyped up in terms of its activation for pain. Then there's sustained neuronal firing of C fibers, one of those fibers. And they fire and release and transmit impulses into the dorsal horn of the spinal cord, where there is chaos that occurs. There's a release of excitatory amino acids, and one of those amino acids, excitatory amino acid, is glutamate. Glutamate excites receptors in the dorsal horn, and they're called N-methyl-D aspartate receptors, NMDA receptors, and that leads to chaos in the dorsal horn, and any input coming into the dorsal horn is met with an increased sensibility to pain, and this is central sensitization, a very, very complex process. And if you just look at more specifically, drill down into the dorsal horn, you can see that there's afferent pain fiber input that goes into the dorsal horn. And as a result of that, there is an increased sensibility of pain in the dorsal horn because of this release of excitatory amino acids. And that state leads to central sensitization. That's a complex mechanism that sustains chronic pain. So we try to prevent, reduce, and reverse central sensitization, but it's not so easy. We try and prevent central sensitization by being very aggressive with acute pain management. But now we're in a new era in pain management, and I wanted to talk a little bit about that. What is that new era? Well, first of all, one of the new discoveries in terms of interprofessional pain competencies and nursing pain competencies is the fact that we have identified 4 areas now for pain competencies for practitioners: multidimensional nature of pain, pain assessment, pain management, and clinical conditions. And this article that resulted in a summit on interprofessional pain competencies outlines what has to be achieved in these categories. However, we just recently got done looking at the medical licensing exam, the United States medical licensing exam, and the items on that exam for medical students and beginning physicians to be licensed in medicine, and what that pain content looked like. And there was a predominance of items related to pain assessment and far fewer items related to pain competencies in the domain 1, domain 3, and domain category. So this overrepresentation of pain assessment questions was there, but not necessarily questions related to competencies for the management of pain and understanding the pain experience itself. Now, we are in a new era of having a national response, the pain strategy, the national pain strategy. And this is a multi-level comprehensive report that addresses and strategically focuses on professional training, public education and communication, service delivery, reimbursement, prevention and care, and disparities in pain management and access to care. And drilling down into this comprehensive national report that is to really guide our efforts in pain management, there are 3 points that I'd like to make. One is that the National Pain Strategy emphasizes the prevention of the progression of acute pain to high-impact chronic pain. There's no question that this is a national priority. Next, it encourages nurses and all healthcare professionals to adopt an evidence-based, accepted standard practice for interdisciplinary pain care. And it illuminates the professional accountability that nurses share with other healthcare professionals in ensuring that optimal and equitable pain care is available to all patients. Now, the National Pain Strategy has been very influential in actually emphasizing the importance of multimodal analgesia as a strategy for preventing acute pain transitioning into chronic pain, high-impact chronic pain. And multimodal analgesia employs combining classes of pharmacologic agents that target different pain mechanisms and pathways. And I just have listed, and we're going to go over this in a bit, some of the multimodal analgesic strategies for acute pain, such as systemic analgesics, neuraxial therapy, epidural and intrathecal interventions, peripheral nerve block interventions, intra-articular and wound infiltration with local analgesia. These are all examples of multimodal analgesia strategies because each of these analgesics and each of these techniques targets a particular pain mechanism or pathway. And it's the combination of this aggressive strategy that makes multimodal analgesia the preferred strategy or approach to treating acute pain. Now, we have to look at the prevention of acute pain. And because if we prevent acute pain, or at least the worsening of acute pain, we minimize the likelihood for acute pain to transition into a chronic pain state. And so for acute surgical pain, we have adopted a newer terminology called preventative analgesia. We used to use the term preemptive analgesia, where we would be giving analgesia before an incision or surgery was done. But preemptive analgesia is now replaced with a very encompassing term, preventative analgesia. And in the postoperative setting, preventative analgesia would be all of the approaches that would be used preoperatively, intraoperatively, and postoperatively that would be expected to reduce nociceptive activity at the injury site, thus reducing the severity of acute pain. But also in our national strategy, we have to deal with the opioid crisis that has surfaced its ugly head in terms of our society. And this opioid crisis recognized, it's always been a crisis. We've always had it. It's nothing new. These are data from 2014 when we began to pay attention to the numbers of deaths that occurred, drug overdoses, and some of these occurring in patients who had chronic pain or pain and were using opioid analgesics. And as a result of this opioid crisis, the CDC, the Centers for Disease Control, responded with a very powerful publication that outlined recommendations for prescribing opioids for chronic pain in the United States. So you can see that the title is very general, but this powerful document changed practice overnight because what it did was it got everyone, prescribers and recipients and administrators of opioids, paying attention to this problem. But in actuality, these guidelines are just related to chronic non-cancer pain. And they are guidelines that clearly, they're recommendations, not evidence-based guidelines, that clearly recommend certain approaches to the management of chronic non-cancer pain. They do not apply to acute post-surgical pain. They do not apply to the palliative care setting, and they don't apply to cancer-related pain, in advanced cancer-related pain. But what happened was the strategies that were outlined for these guidelines and recommendations for chronic non-cancer pain evolved into recommendations for when to initiate or continue opioids for chronic pain, how to select opioids, and how to assess and address the harms of opioid use. But the actual collateral damage, if you will, in terms of this report in withholding opioid analgesics from patients who might really need them has really been felt across the healthcare system. And so one of the things that has happened is that we see there's a response to the opioid crisis, and that response has been to not only reduce the prescribing of opioids in chronic non-cancer pain, which was its intent, but to reduce the prescribing of opioids in pain in general, which can be a good thing. We can more responsibly use and prescribe opioids. And want to just share with you some data from the CDC that was published in the weekly report, Morbidity and Mortality. This is a very powerful slide. These are simulated data, projected data of the probability of being on an opioid analgesic or continuing use based on the days of your first opioid prescription supply at 1 year and 3 years. So if you were prescribed an opioid that was 40 pills for your days of, 40 days for your days of your first opioid prescription, the likelihood of you being on opioids at 1 year would be around 40%, and at 2 years would be around 20%. The number of prescriptions that you get in the first episode of opioid use is equally as powerfully projected in where opioid naive patients would be if they were prescribed opioids, if they were prescribed numbers of opioid prescriptions. So that you can see if a patient was given 8 opioid prescriptions, they have a very high likelihood that they would have a high 1 year probability of almost 80% of being on opioids. And you can see having a very high 3-year probability of about 50% of being on opioids. So we paid very close attention to this. And so what has happened, we're getting much more cognizant of the importance of restricting the use of opioids with acute pain, restricting the days supply, restricting the number of pills in a prescription, and restricting the number of prescriptions. Now, the CDC recommendations for chronic non-cancer pain are the following. Excuse me. But you can see that utilizing multimodal analgesia is paramount in their recommendations. And the recommendations suggest that multimodal analgesia should be the standard for care, and that we should use other analgesics devoid of opioids as the first line of therapy for patients. But it also emphasizes that we should be paying attention to the harmful effects of opioids, and that we should know the risk factors and the increased susceptibility to opioid-associated harms. Now, if we continue with some of the recommendations, there are recommendations for chronic non-cancer pain to assess the risk periodically, and that these risk factors, especially of patients on opioids or being prescribed opioids, their risks do change, so we have to be aware of that. And to maximize non-pharmacologic and non-opioid pharmacologic therapy for chronic pain. Now, mitigating risks with opioid analgesics are also strategies that we need to consider, and that's avoiding prescribing opioids for patients at risk for misuse, abuse, and addiction in the treatment of both acute and chronic pain. Practicing multimodal analgesia, combining different analgesic techniques to maximize the pain-relieving effects. Considering informed consent when prescribing opioids, where that if patients are receiving opioids for greater than 3 months, it clearly outlines what the risks are and what the expectations are. Urine detection monitoring is something that we've been looking at for patients on chronic opioid therapy, opioids greater than 3 months. Being evidence-based and best practice concordant. I can't stress that enough. And to engage in interprofessional practice so that our clinical decisions about patients are made together so that we, in the best interest of the patient, and that we each know our specific role in relieving pain and managing patients on opioids. Now, risk factors for opioid misuse and use disorder are outlined on this slide, and I think that this is a very comprehensive sort of list of many of the risk factors for misuse and opioid use disorder, which we would frame as addiction, but the more appropriate way of characterizing this is opioid use disorder. You can see that there's demographics. You can see that psychiatric history also plays a role in risk for misuse and use disorder. History of pre-adolescent abuse, post-traumatic stress, and again, history of substance use, obviously, strongly predicts those who might have the likelihood to have opioid misuse and use disorder. And we also have plans to put in place for patients with acute pain and chronic pain who are managed in primary care settings. And this is just a sequential sort of guide in terms of monitoring and attention to some of the practices that we want to really be careful about, and that's co-prescribing opioids with high-risk medications and identifying patients who are at high risk for substance use disorder. And also chronic pain co-interventions is using multimodal analgesia and also using other non-pharmacologic agents instead of opioid analgesics. And wanted to just bring attention, because I mentioned urine detection monitoring in patients with opioids as a means for detecting misuse or abuse or adherence to therapy. We just published new guidelines. It was part of a panel. These just came out in January. And these guidelines put forth recommendations that are evidence-based for how often we should monitor patients for urine detection for their opioid use. And obviously at baseline, before we start patients, we really should have a practice for urine detection monitoring. But it also talks about if the patient's at risk what would you do? And if low risk, we set minimal standards for at least annually. If moderate risk, at least greater than 2 times per year, and these would be random. And at high risk, urine detection monitoring would be greater than 3 times per year, and again, these would be random. And for urine detection monitoring practices as part of the informed consent and expectations, patients would be told and informed that this was a condition of their care. So we've set the stage for what's happening nationally, the CDC guidelines for non-cancer pain, the recommendations to more closely monitor patients who are on opioids, and the recommendations that we use multimodal analgesia. And multimodal analgesia is not a new concept. It's been widely used in Europe. It was first mentioned and identified the concept by Acute, a researcher in Europe. And we have just recently been, we've always been doing multimodal analgesia, but we've been recently paying attention to calling it multimodal analgesia and to being more strategic. This is a slide that I really like, which superimposes the 4 areas that I talked about: transduction, transmission, perception, and modulation on the pain pathways, and lists the classifications of analgesics that act on those mechanisms and pathways. So you can see those analgesics that interfere with transduction and those analgesics that interfere with transmission. And remember, transmission was the propagation of an electrical impulse that was conducted along the nerves that goes to the dorsal horn. And we know that gabapentinoids such as gabapentin and pregabalin are membrane stabilizing drugs that actually reduce the irritability of nerves and that transmission of painful impulses. So this would be very helpful to always be strategic in how your selection of multimodal therapies analgesic therapies will actually have an effect on mechanisms, pain mechanisms, and pain pathways. And multimodal analgesia, these are the drug classes that are most commonly used. So this is really nothing new, and I'm sure you're all familiar, but it's combining these drug classes for the greater effect on pain. I do want to draw attention, you know, the opioids, and you're familiar with the different opioid analgesics, but I do want to draw attention to methadone. And there is a resurgence in interest in using methadone, but both in acute pain and chronic pain, because methadone is believed to be one of the opioids, the only opioid that has an NMDA antagonist activity effect, that it quiets down the NMDA receptors, the N-methyl D-aspartate receptors in the dorsal horn that were activated by those excitatory amino acids that contributed to central sensitization. And everyone always asks for algorithms and guidelines of how to treat pain. These are guidelines and recommendations for acute pain and acute postoperative pain, but can be generalized to trauma pain. And these recommendations were published in 2016, and there are about, I think, 24 recommendations. But these evidence-based guidelines go over all of the different surgical procedures, and this is an example in this table, and the multimodal strategies that have been studied with benefits in the treatment of that particular post-surgical pain condition. And you can see that they also list the non-pharmacologic therapies that have been effective, and most often the cognitive modalities, cognitive behavioral therapy, are very helpful. Relaxation therapy, and hypnosis and biofeedback, both with acute and chronic pain. But these are often difficult to practice in an acute care setting and are most often used in a chronic care setting. And then there are other evidence-based guidelines and resources for acute pain, and we actually published an article last spring in AJN on evidence-based resources for acute pain. So here are further guidelines, evidence-based guidelines that give recommendations and support the treatment of acute pain and multimodal analgesia. But by far, this document, the Acute Pain Management Scientific Evidence by the Australian and New Zealand College of Anaesthetists and Faculty of Penn Medicine, this is the most authoritative document. You can download it. It has levels of evidence for every single type of analgesic technique that you can think of for acute pain, and you can search it. It's a 780-something page document, but it's a PDF, and you can search it very easily for anything that you're interested in terms of treatment of acute pain, and it'll tell you what the level of evidence is. So, for example, a common practice in the emergency department is giving opioid analgesics to migraineurs, patients with migraines. And if you go to this document and you search for headaches, it will give you the evidence that opioid analgesics are not effective in acute migraine pain, and will give you some alternative therapies. We also have a trend in opioid-free analgesia to try and reduce the use of opioid analgesics, which again, we are concerned about the use of opioid analgesics in acute pain because of the opioid crisis, and because the fact that patients who we know use opioids for acute pain can transition to need them for chronic pain. And opioid-free analgesia has been looked at, and preliminary findings, particularly for postoperative pain, it's used in enhanced recovery after surgery protocols, ERAS protocols, that do promote multimodal analgesia. Opioid-free analgesia, the benefits is reducing the incidence of vomiting, ileus, and delirium. Opioid-free analgesia is also used in the ICU when you want to not use opioids in case of delirium. Opioid-free analgesia promotes early feeding and discharge, but a meta-analysis of opioid-free analgesia and what kinds of techniques other than multimodal analgesia would be beneficial showed that electrotherapy and acupuncture after total knee arthroplasty were associated with reduced pain and opioid and delayed opioid use. But it's very hard to use acupuncture in a hospital-based setting without the resources for an acupuncturist to administer it. So this type of analgesia might not be feasible. It's important to understand that data show that these protocols may not have an impact on discharge, and this is important. That opioid-free analgesia protocols have shown to reduce the use of opioids while they're in the hospital, but we still need more studies because it doesn't look like they have a significant impact on discharge use of opioids. And of course, we're concerned with that also and restricting opioid analgesia. Now, I wanted to bring attention that if we are using opioids in the hospital, we really need to be mindful about safety for patients and making sure patients are monitored for advancing sedation from opioids and respiratory depression. And these are just some studies that we did. The first one here in the left-hand corner, we actually studied pain management nurses to look at monitoring practices and found that there were many patients who were at risk for respiratory depression and sedation who weren't adequately monitored. In 2011, we came up with, 2 years after we did the survey, we came up with evidence-based guidelines for monitoring, and we let them infuse into practice, or at least we hoped, before we surveyed again 3 years later. And what we found in the subsequent survey is that there wasn't much change after the evidence-based practice guidelines were introduced. And this is not surprising. It's not surprising that we are very far behind in using evidence-based practice guidelines in relationship to pain. And we have a lot of work to do to bolster our alignment of practices with the evidence. As far as when to and who is at high risk for this unintended advancing sedation and respiratory depression, by far after surgery, it's patients with IV PCA. In the first 24 hours, there's a risk for a respiratory event that's higher, and opioid-related sedation is the greatest after 4 hours from discharge from the post-anesthesia care unit. And generally, that's when we get patients settled in their bed and we try to encourage them to sleep. And that may be a time with sedation that they're very vulnerable to their sedation, unintended advancing sedation, also transitioning into respiratory depression. So we want to make sure that aggressive monitoring practices, sedation levels, pulse oximetry, or end-tidal CO2 monitoring, technology monitoring, as well as respiratory rates are assessed. And we just, for the purposes of educating nurse educators and practice leaders, we developed a strategy and an article that's published that really reviews all of the hospital-based safeguards that need to be put in place to keep patients who are receiving opioids in the hospital safe. And one of them is monitoring, and the other is actually having a tracking system for the use of naloxone, Narcan, as many of you know, to reverse analgesia. And that's an indicator, obviously, if naloxone use is high, that there may be a need to reverse unintended advancing sedation and respiratory depression. But tracking it also to understand that we also use naloxone to treat other side effects of lower doses of naloxone to treat other side effects of analgesics, of opioid analgesics. There are no algorithms or recipes that are really helpful in practice for chronic non-cancer pain, although there are chronic non-cancer pain evidence-based practice guidelines. And these guidelines are not new, and they've recommended from the time they were published in 2009 not to use opioid analgesics for certain chronic non-cancer pain syndromes, and to maximize therapy, again, with multimodal analgesia. So we get back on the topic of multimodal analgesia, and we need to go through then the classes of the analgesics that are used. And non-opioids are very beneficial in both acute and chronic pain. NSAIDs, as you know, can be very effective. We have to be careful with chronic use in older adults with NSAIDs. They really should not be given round-the-clock use of NSAIDs. They should be given PRN, which we really don't use PRN NSAIDs for chronic pain. We generally use them more regularly, but in older adults who may be vulnerable to GI bleeding, cardiovascular risk, and renal toxicity, we have to be very careful. There's also acetaminophen, and we have oral acetaminophen, but we also have IV acetaminophen. And IV acetaminophen is used for acute pain in the hospital setting. Generally, patients get a dose after surgery, and then they may get 4 doses per day of 1,000 milligrams. There's debate about the effectiveness of IV acetaminophen, and there's no debate about the fact that it does peak earlier, and it does its peak earlier may or may not be associated with effective analgesia, but it does play a role in treating patients who are unable to take oral acetaminophen. Anticonvulsants are used. Gabapentin and pregabalin are the gabapentinoids, and we use this in these drugs in neuropathic pain conditions, as well as fibromyalgia for chronic pain, but we also use them for postoperative pain, and we give these drugs preoperatively as multimodal analgesics agents for pain prevention. So these are channel modulators, these drugs, and they do interfere. They're membrane stabilizers, and they do interfere with the irritability of nerves and the firing of nerves and the transmission of painful impulses. Gabapentin and pregabalin for preoperative and postoperative use, as I mentioned, as pain prevention. Doses may vary. We usually give very high doses in patients with chronic pain. In patients with, and high doses would be anywhere from over 1,200 milligrams per day. In patients with acute pain, we generally give anywhere from 300 or even 150 as low as to 600 milligrams and sometimes 900 milligrams a day. Associated with preoperative use, gabapentin has been very effective in ameliorating or reducing pain with joint replacement. And remember, I showed those statistics that are just newly recognized and appreciated with total hip and total knee replacement patients developing a chronic pain syndrome. And you have to be cautious with the use of gabapentin and pregabalin with patients who are older. These are just some recommendations for preoperative use of anticonvulsants such as gabapentin and pregabalin and the doses that we would use. And you have to remember, when patients are having high-risk surgeries for chronic pain, we do try to give them gabapentin preoperatively, and they may be having a surgery and they may be feeling well, working before surgery, and we have to be really careful because these drugs can be sedating, so they may not be able to tolerate very quickly high doses. Antidepressants are also used, and these are primarily used for chronic non-cancer pain and cancer pain, chronic cancer pain, but they are also used for preoperative and postoperative multimodal analgesia. Tricyclic analgesics, you can see amitriptyline, nortriptyline, and desipramine is more norepinephrinergic. And the interesting thing is that descending pathway that I showed you, having more norepinephrine available in the central nervous system will actually help with descending pathway modulation of pain versus serotonin. The serotonin neurouptake, norepinephrine reuptake inhibitors, the SNRIs, are much more analgesic, if you will, than SSRIs, the selective serotonin reuptake inhibitors. Based on adverse effects from antidepressants, to just be careful that amitriptyline is associated, Elavil, with the highest incidence of anticholinergic effects, and desipramine the lowest, and we want to really be careful. Ketamine is an NMDA receptor antagonist, and low-dose IV ketamine, which has an analgesic effect and not at anesthetic doses, so these are sub-anesthetic doses, can really help with the prevention of central sensitization and the reduction of central sensitization. Ketamine is an NMDA receptor antagonist. Again, central sensitization that sustains chronic pain is mediated by NMDA receptors. Evidence shows that there are benefits for ketamine in many different treatment settings, And just for example, it can be very helpful in chronic phantom limb pain and residual limb pain following an amputation. Integrative pain approaches everyone always wants to know about, and I think that this is probably one of the most concise slides that I could provide to you in a recent publication that outlines all the integrative pain management approaches. As I mentioned, behavioral and psychosocial approaches are mostly used in chronic pain, but can also be used in acute pain settings. Physical modalities, yoga is gaining popularity, and even in patients with acute pain as an effective. It's used in military populations with chronic and acute pain. Biologic therapies, and many of these don't have significant evidence or strong evidence for their use, but have been used with chronic pain. Certainly the strongest for an analgesic effect in terms of evidence is ketamine. Biostimulation therapies are listed, and auricular acupuncture, it's called battlefield acupuncture. That is very effective and used in the military. Nurses can actually do auricular or battlefield acupuncture, and it can be very effective. And of course, I went over all of the pharmacologic agents and some of the other strategies. Cannabinoids is always an issue, and the topic is way too complex to address. To just say that there are pain relieving effects from cannabinoids that would be cannabinoids different. There are different formulations of cannabinoids, and that they do have pain relieving effects and may be helpful to some patients who need a benefit from neuropathic pain or from the inability to take opioids. So lastly, I want to leave you with the fact that there is evidence for integrative therapies with chronic pain, but the evidence is not strong, and we don't have really good evidence-based guidelines for integrative therapy. So everyone always wants to use them, but you have to really be careful in the population that you're using them with. There is strong evidence for acupuncture, there's no question, to decrease opioid use. And few studies have been able to demonstrate that integrative therapies address the opioid misuse and abuse problem that we have in our society with chronic pain, but we hope to build that science. And obviously, more controlled trials are needed to test integrative therapies. So this concludes our webinar, and in summary, I just want to say that it's really important to make sure that your practice is evidence-based. I've given you many resources to accomplish evidence-based practice, to look at the National Pain Strategy, to read the CDC recommendations for chronic non-cancer pain, and to be informed. And to also, if opioids are prescribed, to prescribe them responsibly with urine detection monitoring, with informed consent, and patient education. So thank you very much, and I will take some questions.
Thank you so much, Dr. Polomano. So we have received several questions, and I'm going to give Dr. Polomano a moment to read those while I give you all a couple announcements that are brief. So first, just a reminder, our next webinar will take place on March 22nd, just next week, and it will serve as an information session about Penn Nursing's new Postmaster's Doctorate of Nursing Practice program. So if you're interested in that, please watch for information and be sure to sign up. And then also be sure to save the date for Dean Furuwell's webinar, which is scheduled for April 26th. And then I think we can go ahead and take a few questions.
So very good question about when is a patient not an opioid naive patient to opioids. Generally, we talk about the use of opioids for regularly for during the acute phase, which would be up to 3 months. And generally, at least 60 milligrams of morphine equivalent and it does vary depending upon what reference, but they would have some level of tolerance. We generally worry about patients who take let's say 5 milligram oxycodone a day for 3 months and think that they're not opioid naive. They probably would be treated as a patient who is opioid naive. What should primary care providers do if the patient has a history of substance use disorder that presents with acute pain and a contraindication to using NSAIDs? That's a very good question. That's a challenge for all of us. Multimodal analgesia, maximize, if you can, therapy with gabapentinoids and with antidepressants. And of course, acetaminophen can be used. And if you, there's always the question about when should you seek support from a pain management specialist, and you should always, if you have that type of patient and their pain is persisting despite multimodal analgesia, you can always send them to a pain management specialist. But if you're not able to see a pain management specialist for a couple of weeks, which is this question, you really have to try to use there's no magic bullet. All of the analgesics, really try some of the, if it's a musculoskeletal, physical therapy can also help. And again, really try to maximize multimodal analgesia without using opioid-based therapy.
Okay. So I think that might be all the time we have for questions today. I'm going to go ahead and wrap up. So again, Dr. Polomano, thank you so much. That was fascinating, enlightening, and a lot of information to take in. So just a reminder about the 2 webinars that are coming up to everyone on the call. And please know that there are several other events that we certainly suggest you check out taking place over the next couple of weeks, including both the 2018 Renfield Award, honoring Vandana Gopikumar, and Alumni Weekend, which takes place in May. Go online and check out the information there. And then finally, I want to encourage all of you to consider getting more involved with Penn Nursing alumni. So no matter where you live, the school really depends on alumni who volunteer their time to interview prospective students, plan and promote events, share job posting, offer support through social media, submit award nominations, and really so much more. You make the school richer by your involvement. So please consider contacting the alumni office for more information, or respond to the post-webinar email that you'll receive and give us your feedback today. So thank you again, Dr. Polomano. Thank you to our attendees, and we look forward to talking to you next time.
Thank you.
Bye-bye.